Hello. Um, we look at how to approach the management of AKI. So usually a patient presents to you with progressive increase in urea and creatinine. That's when you think, look, this could be AKI. How do you proceed? Simply take history and physical examination. Take serial measurements of urea, creatinine, electrolytes. And consider doing a arterial blood gas or venous blood gas. Check the baseline creatinine and then establish AKI. AKI is defined as any of the following: increase in serum creatinine more than or equal to 26.5 micromole per liter within 48 hours, or increase in serum creatinine more than 1.5 times the baseline, uh, which is known or presumed to have occurred within the last 7 days, or urine volume less than zero point 0.5 ml per kilogram per hour for 6 hours. So we can look at the KDIGO classification here at stage 1, 2, or 3. So ideally, try to find out where does your patient fit in. Is it stage 1, 2, or 3? So then move on and think about very systematically the possible causes, which are usually, sepsis, hypoperfusion, toxicity, obstruction, and primary renal disease. Always check for drug dosing, which can worsen the situation, like patients still remaining on antihypertensives, like ACE inhibitors on board, angiotensin receptor blockers, metformin, potassium sparing diuretics, and all which can accumulate as well. And remember, response to therapy is an important part of the diagnostic approach. So, so sometimes if you want to differentiate pre-renal from renal and post-renal, simply um, you know giving a bolus of fluid and their blood pressure rising up and then producing urine output could very well be indicative of a hypovolemic situation causing pre-renal, and simply catheterizing them could help sometimes find out that it's post-renal. So the response to therapy is quite an important part of the diagnostic approach, and it's very important we realize it and we use it appropriately. A fluid responsive hypotension or fluid unresponsive oliguria or anuria, consider referral to ITU. I think this is quite important because what often happens is a patient is identified to be in AKI, and the hypovolemic or hypotensive, people give fluids, they realize it's pre-renal and they keep giving fluids, which is not very helpful because if they are fluid unresponsive, then better consider escalation to ITU because they may require vasopressor support or inotropic support as required, and depending on the problems in their physiology. Now, if your patient has anuria, then you have to check whether your patient is anuria or oliguria. If they have oliguria, then you have to consider likely a pre-renal problem. But if abrupt anuria, that could be suggestive of acute urinary obstruction. So a gradually diminishing urine output may indicate a urethral stricture or bladder outlet obstruction, like due to prostate enlargement. And if you think the patient has oliguria, what you can always do is measure urinary and serum sodium and creatinine levels and osmolarity levels. So, unlike in pre-renal conditions, as you can imagine, this urinary sodium will increase, and also the urine osmolarity is going to increase because the urine will be concentrated. Okay, and serum urea levels will increase because urea tends to get reabsorbed with a sluggish circulation, as in pre-renal situations, whereas creatinine gets eliminated. It doesn't get reabsorbed. So you'll have a disproportionately rising urea compared to the creatinine. Now, so if you think it's pre-renal based on findings from your urine and serum sodium, urea levels and creatinine levels and osmolarity, then the possibilities are usually volume depletion or congestive cardiac failure. If it's volume depletion, they respond well to IV fluids. It's congestive cardiac failure. If you suspect that, you may have to do an echocardiogram, cardiology referral, CC or ITU and level care, and treatment plans. Now, if the patient is anuric, we are going to the second part here. I would order a renal ultrasound as early as possible. And if you find a normal sized kidney, it could be renal parenchymal disease, could be glomerular, tubular, or interstitial problems. A further specific lab test and urine analysis will help us find this or clarify this. Whereas if there's hydronephrosis, then it's obstructive, it's a post-renal problem. Or bilateral small kidneys, that could be indicative of chronic renal failure. So your early renal ultrasound could be very helpful. Okay, now let's look at history. Now, various factors to be considered in history. I would take quite a detailed history about comorbidity, specific etiologies, drug history, and social history. In comorbidity, people with these following comorbidities are at a high risk of developing AKI, hypertension, chronic heart failure, diabetes, liver disease, obesity, multiple myeloma, chronic infections, myeloproliferative disorder, connective tissue disorder, autoimmune disease. Or they fall into known chronic kidney disease. And what's important is chronic kidney disease itself is an important risk factor for developing AKI. Even a trivial nephrotoxic insult may cause AKI to be superimposed on chronic renal insufficiency. Now, about specific etiology. Did the patient have any volume restriction? Example, low fluid intake, gastroenteritis. Has the patient suffered hypovolemia? Did the patient have any nephrotoxic drugs? Did the patient take any overdose of any drugs which are likely to be nephrotoxic? Was there any exposure to iodinated contrast agents within the last week? Was there any trauma or unaccustomed exertions? Was there any blood loss or transfusions? And was there any exposure to toxic substance such as ethyl alcohol or ethylene glycol? Exposure to mercury vapors, lead, cadmium, or other heavy metals which can be encountered in welders and miners. So plenty of things to consider. So you would always ask, was there any hypovolemia, any nephrotoxic drugs, any toxicity, any contrast, and was there any trauma, or especially you can imagine myoglobin, anuria, myoglobin getting precipitated within the tubules. Was there any blood loss or transfusion associated reactions? So those are the specific etiologies I would consider. In drug history, it's not a bad idea asking about over-the-counter formulations and herbal remedies or recreational drugs. And there are toxicology risks with any overdoses. And also, I would like to know if the patient is taking any non-steroidal anti-inflammatory drugs, angiotensin receptor blockers, ACE inhibitors, potassium-sparing diuretics, metformin. And in social history should include exposure to tropical diseases. Has the patient had any travel recently, to tropical weathers? Example, malaria can be there, waterways or sewage systems, and exposure to rodents. I think risk of leptovirus, hantavirus, etc. Now let's look at the differential diagnosis of acute renal failure. So we're looking at pre-renal, intrinsic acute renal failure, and post-renal acute renal failure. How do we arrive at these diagnoses? So I think you have to suspect pre-renal acute renal failure under certain circumstances. If there is true intravascular volume depletion, there's true intravascular volume depletion, decreased effective circulating volume to the kidneys, impaired blood flow because of exogenous agents. Now let's look at each one of these. True intravascular depletion, what do I mean? Gastrointestinal losses or renal losses, skin or respiratory losses, and third space sequestration, as in crush injury or skeletal fractures, or decreased effective circulatory volume to the kidneys, as in hypotension. A severely decreased blood pressure can result from shock and post-treatment of severe hypertension. Edemata states like cirrhosis, splanchnic venous pooling, and systemic vasodilatation can decrease effective circulatory volume. Heart failure can decrease the cardiac output. Selective renal ischemia, as in bilateral renal artery stenosis or unilateral stenosis, made worse by treatment with angiotensin converting enzyme inhibitors or angiotensin 2 receptor blockade or direct renal inhibitors. And impaired renal blood flow because of exogenous agents, lowering the intraglomerular pressure that drives this process, and as can happen with decreasing either afferent arterial dilatation, example as with non-steroidal anti-inflammatory drugs or calcineurin inhibitors, efferent arteriolar constriction, which gets affected as with AC inhibitors or angiotensin 2 receptor blockers, and they essentially cause impaired renal blood flow and thus lowering the intraglomerular pressure. Okay, so they could contribute to pre-renal acute renal failure. Now let's look at intrinsic acute renal failure. Quite a few of them. So there could be a tubular problem, a glomerular problem, vascular problem, or interstitial problem. Okay, as you can see. Okay, let's look at a tubular problem. Like due to ischemia, it can happen due to ischemia or due to toxins. So all cases of pre-renal disease, particularly if accompanied by hypotension, surgery, or sepsis, can cause post-ischemia, ischemic acute tubular necrosis. Essentially, if it's long-standing, the organ gets ischemic. So ischemia causes acute tubular necrosis. So pre-renal hypotension, hypoperfusion can finally lead to an acute tubular necrosis and turn into intrinsic acute renal failure. Toxins like aminoglycosides, contrast agents, pigments, myoglobin or hemoglobin, they can all cause acute tubular necrosis. Now, glomerular diseases, let's have a look. Rapidly progressive glomerulonephritis, as can happen in SLE. Small vessel vasculitis, as can happen in Wegener's granulomatosis or polyarteritis nodosa. Henoch-Schönlein purpura or immunoglobulin A nephropathy or Goodpasture syndrome. They can all cause glomerular diseases. Vascular diseases, we can broadly divide them into microvascular diseases and macrovascular diseases. Microvascular are atherosclerotic diseases, like due to cholesterol plaque microembolism, thrombotic thrombocytopenia purpura, hemolytic uremic syndrome, HELP syndrome, or postpartum acute renal failure. They are all kinds of microvascular diseases, essentially leading to intrinsic acute renal failure. And macrovascular conditions are renal artery occlusion, severe abdominal aortic aneurysm. They can all lead to vascular diseases causing intrinsic acute renal failure. Interstitial diseases could be immune-related, infection-related, or infiltrative. Immune, infection, or infiltrative. Immune ones, let's have a look. Like allergic reaction to drugs can cause interstitial nephritis. Autoimmune disease like SLE or mixed connective tissue diseases can cause. And infections like pyelonephritis can cause interstitial diseases. Infiltrative disease like lymphoma, leukemia can cause interstitial diseases. So the interstitium can get affected with immune, infection, or infiltrative conditions. So, but often common one is usually drug-induced interstitial nephritis. That is usually what is discussed most commonly. Post-renal acute renal failure. Yeah, they can happen under these circumstances where prostate gets affected, as in benign prostatic hypertrophy or prostate cancer, bladder, as in intraluminal bladder mass, clot, tumor, or fungus ball, neurogenic bladder, urethra gets affected with urethral stricture, cervix, as in cervical cancer, retroperitoneal fibrosis, intratubular obstruction, as in crystals or myeloma light chains. Right, now we look at probable causes of acute renal failure based on physical findings. Right, so if look at the vital signs, so do your systemic examination properly. Look at the vital signs. If the temperature is high or low, you can suspect infections. The blood pressure is, check the blood pressure. If the blood pressure is high, then you have to consider nephrotic syndrome or malignant hypertension causing renal injury, and hypotension causing volume depletion or sepsis, due to volume depletion or sepsis. If there's weight loss or gain, that helps check whether there's hypovolemia or hypervolemia, hypo or hypervolemia. Examining the mouth can give clues to dehydration. Looking at the jugular veins and the axilla can give you clues to hypovolemia or hypervolemia. Pulmonary system, yeah, you can always, check if there's any crepitation, which could be signs of congestive cardiac failure. Heart, a new murmur of endocarditis or signs of congestive cardiac failure. So it's very important that we do a thorough examination, systemic examination. Abdomen, bladder distension suggesting urethral obstruction. Pelvis, if there's any pelvic mass, you got to pick it up. Rectum, if there's any PR examination suggestive of prostate enlargement. Skin, you can look at the skin and check if there's any rash of interstitial nephritis. Purpura of microvascular diseases. And or you can, like I've mentioned here, so these purpura of macrovascular diseases, or a liver diverticulitis suggestive atherembolic disease, or splinter hemorrhages, or Osler's node of endocarditis. Right. Okay, so we've discussed the probable cause of acute renal failure based on physical findings. Now, what the diagnosis? How will you diagnose systematically the causes and treat? So, mnemonic STOP really is very helpful, as used by the London AKI, which is sepsis, hypoperfusion, toxicity, obstruction, primary renal disease. So let's look at them. Sepsis. Always do a sepsis screen properly if you suspect sepsis. Do the sepsis fix antibiotic. Always identify the source. And consider the need for source control. Do not wait. Expose the patient fully. Ensure do consider the need for source control. And imaging if required, early imaging to find the source. The patient in septic shock, that is fluid unresponsive hypotension with increasing lactate, you escalate to ITU. Do not waste any time. And then let's look at sepsis, and then we're looking at hypoperfusion, which can happen with hemorrhage, dehydration, cardiac failure, liver failure, renovascular insult. Example like aortic surgery. So I think I'll just clarify a few points here. It's very important to understand the peripheral perfusion to vital organs is primarily based on improving the oxygen delivery. It's all about ensuring oxygen is delivered to the peripheral tissues. And for oxygen to be delivered to the peripheral tissues, oxygen has to be bound to hemoglobin. So that's your oxygen content calculation. I've just given you the formulas there. Oxygen content is actually the hemoglobin, a product of hemoglobin, and how well it's saturated. Hemoglobin in gram per deciliter multiplied by the oxygen saturation, plus the dissolved fraction in plasma. So there has to be good oxygen content. and there has to be a good cardiac output which generates a flow which takes the oxygen content forward. At the same time, there has to be a good squeeze or peripheral resistance which generates a good blood pressure, and the driving pressure becomes the mean arterial pressure, or the mean arterial pressure is considered the driving pressure. So that's very important to realize, that to take this hemoglobin which is fully saturated with the forward flow, there has to be good squeeze on the blood vessels. Okay, and we also ought to know that the cardiac output which is responsible for this flow is determined by the stroke volume and heart rate. It's a product of stroke volume and heart rate, and the stroke volume depends on three factors: preload, contractility, and afterload. So each of this, if affected, can in turn affect the cardiac output, and in turn can affect the oxygen delivery. Okay, now about the regional blood flow, you got to know a few things. The regional blood flow, as I've shown here, is equal to, the formula is mean arterial pressure minus central venous pressure or compartment pressure divided by the organ vascular resistance. Okay, and the mean arterial pressure minus called the perfusion pressure. And so if the perfusion pressure is divided by the organ vascular resistance, you get the regional blood flow. Now, very important to realize, the mean arterial pressure is the driving pressure. It can also be calculated as the diastolic pressure plus 1/3 of the pulse pressure. Okay, where the pulse pressure is a difference between the systolic and the diastolic blood pressure. So all I'm trying to say here is, look, whenever there's hypoperfusion, you have to have a good, thorough understanding of all these formulas, and they are not complex, but the principles are that oxygen need to be well bound to hemoglobin, that hemoglobin content has to be adequate, it has to be well saturated, the cardiac output has to be good enough, and the cardiac output is dependent upon the stroke volume and the heart rate. So if the heart rate is poor, or there's brady or tachyarrhythmias, then you have to do the ALS protocols, which is essentially you have to attempt rate or rhythm control so that the cardiac output is maintained. And the stroke volume is also dependent on preload, contractility, and afterload. It's very important to realize that it's dependent on all three. Often the mistake that we notice is people start giving fluids, but without realizing, without generating a good blood pressure, without realizing that it could be a large preload deficit, or it could be a problem with contractility, or it could be a problem with the afterload. And that's why a patient is unable to generate a reasonable cardiac output or blood pressure. And therefore, the patient needs to go to ITU, and probably needs to be done early. So that's the important bit. And that's why I've tried to say that. Not only that, even if you optimize the central oxygen delivery and the blood pressure and the cardiac output, it doesn't guarantee that blood flow will reach the kidneys or peripheral organs, because the organ blood flow is dependent upon, the regional blood flow is dependent upon the mean arterial pressure minus central venous or compartment pressure divided by the organ vascular resistance, which means if the organ vascular resistance is high, like in hydronephrosis or other situations, blood may not flow adequately. Suppose if the compartment pressure is high, suppose intra-abdominal compartment pressure is high, more than the CVP, then the opposing pressure is the abdominal compartment pressure, and the difference is what really drives the blood flow. The difference in this pressure is what drives the blood flow, which will not happen as well. Okay, now let's go to obstruction. You have to consider obstruction, and ideally, you have to consider all these kind of bladder outflows, stones, tumor, surgical ligation of ureters, extrinsic compression, retroperitoneal fibers. All this have to be considered if you're considering obstruction. It's good to perform a renal tract imaging, ultrasound or CT/KUB in less than 24 hours. Okay, but if obstructed and infected urinary tract, suspected pyonephrosis, you ideally image as early as possible, ideally less than 6 hours. If likely or suspected obstructed AKI, you should refer to urology. And target time to relief of obstruction, immediate if infected, otherwise 12 hours after diagnosis. So if somebody's infected, you better image very fast and very fast referral to the urology team, okay, or within 24 hours. Right. Toxicity. Look out for potential nephrotoxins and remove or limit them. Example, non-steroidal anti-inflammatory drugs, AC inhibitors, angiotensin receptor blockers, aminoglycosides, amphotericin, radiocontrast toxins, etc. So, and primary renal disease. So you have to consider all these possibilities: glomerulonephritis, tubular interstitial nephritis, rhabdomyolysis, hemolytic uremic syndrome, myeloma of the kidney, malignant hypertension. If likely or suspected primary renal injury, refer to nephrology. So if you think your patient has got a primary renal disease, inform the nephrologist or the renal physician. So acute glomerulonephritis and vasculitis management may also require corticosteroids, cytotoxic agents, or immune modifying drugs. Okay. Now about urine analysis. I think urine analysis is quite important. It gives early clues to what could be the problem. So I would always say, yes, always do a urine dipstick and perform urine analysis. That'll give you early clues to what the condition is like. So if it's pre-renal acute renal failure, you're likely to get scant or few hyaline casts. And treatment is treat underlying cause, as we said before. If it's post-renal acute renal failure, you could get few hyaline casts, possible red cells. If it's acute tubular necrosis, you're likely to get low-grade proteinuria, renal tubular cells, renal tubular casts, or pigmented casts. If it's allergic interstitial nephritis, you may get eosinophils, possible white cell blood cell casts. You may get low to moderate proteinuria. You should eliminate the offending drug and consider steroids. A moderate to severe proteinuria with red blood cell casts you could get in glomerulonephritis, and then you may have to consider renal biopsy in those cases. Multiple myeloma is a possibility. Where you would get moderate to severe proteinuria and red blood cell casts. You should consider doing a serum and urine immunoelectrophoresis. If heme is positive but no red blood cells, but you're getting hemoglobinuria, myoglobinuria, you should check the CK levels or creatine kinase levels. If high, consider rhabdomyolysis. You got to hydrate them well. Okay, so it could be a case of rhabdomyolysis. And RBCs, WBCs, cellular casts, proteinuria, bacteria, positive nitrite, and leukocyte esterase in case of infections. So I think if you do a urine analysis, you're likely to get some clues, especially if there's excess proteinuria. You got to suspect glomerulonephritis and multiple myeloma. These are things that you would consider. And this infection, as you said here, you could have all these situations where you may have bacteria, positive nitrites, leukocyte esterase, etc. Right, okay. And now let's look at the finding of blood tests for specific type of acute renal failure. If you have elevated uric acid levels, it could be suggestive of malignancy or tumor lysis syndrome leading to uric acid crystals, also seen in pre-renal acute renal failure. Elevated CK or myoglobin levels, as in rhabdomyolysis. Elevated prostate-specific antigen in prostate cancer. Abnormal serum protein electrophoresis in multiple myeloma. Low complement levels, as in SLE, post-infectious glomerulonephritis, subacute bacterial endocarditis. Positive anti-neutrophilic cytoplasmic antibody, as in small vessel vasculitis, Wegener's granulomatosis, or polyarthritis nodosa. Positive anti-nuclear antibody to double-stranded DNA, as in SLE. Positive antibody to glomerular basement membrane, as in Goodpasture syndrome. Positive antibodies to streptolysin O, as in post-streptococcal glomerulonephritis. Schistocytes on peripheral smear. Decreased haptoglobin levels, elevated lactate dehydrogenase level, or elevated serum bilirubin levels, as in hemolytic uremic syndrome or thrombotic thrombocytopenic purpura. And so quite important. If you really suspect this condition, then you should send a peripheral smear. You should look at the haptoglobin levels, look at the LDS level or elevated, check the bilirubin level as well. Try to put it together. Low albumin levels, as in liver disease or nephrotic syndromes. So now coming to management. So how would you manage? I think it all comes down to supportive management and awaiting resolution of renal insufficiency. If there's worsening urea and creatinine with single organ failure, but hemodynamically stable, consider refer to renal physicians for hemodialysis. There's worsening clinical status like hyperkalemia, acidosis, pulmonary edema, fluid overload, encephalopathic, hypotensive, and any impending organ failure, you refer to IT for renal replacement therapy. Severe AKI3 should be discussed in nephrology and critical care regardless of the cause. General supportive care and escalation. Once patient is euvolemic, you can give maintenance fluids, example, output plus 500 mLs. By looking at the fluid chart, daily weights, regular fluid assessment, etc. So regular, at least 4-hourly observation and early warning scoring system with clear escalation plan while we are maintaining them in the wards. Consider dietitian review and nutrition being sorted out. Monitor for complications and review all drug dosages. These are the general supportive care and escalation that we will do. Okay, perfect. Thank you very much, guys. Let's hope this has been helpful. And thank you.